so much to the Institute for Food and Health for inviting me today to talk about my research. I'm based in the UCD School of Medicine. My group have a big interest in the role of metabolic inflammation in obesity, and in particularly in developing novel biomarkers of this metabolic health inflammation in order to better risk stratify patients with obesity. So my talk today is in kind of two halves. The first talk, I'm going to talk about some of the research from my group. And the second part of the talk, I'm going to talk about a new project that has started in UCD that's being led by UCD. It's an innovative medicines initiative project to optimize future obesity treatment. And it's being coordinated by Professor Carl LaRue, and I'm one of the investigators on this project. So I just want to introduce the project to the Institute today. As we all know, obesity is a very complex and multifactorial disease, and much more complex than we had originally anticipated, as being a lifestyle choice of too much energy in and too little energy out. We now know this is a massive oversimplification of obesity, and there are potentially lots of different subtypes and different clusters of patients with obesity. And the objective of SOPHIA is really to try and understand these different clusters and the risk factors that are associated with these clusters. So what we're trying to identify in SOPHIA is the highest risk patient populations with obesity that require better intervention and better care. So in parallel to understanding the highest risk groups, we also need to know how to treat those groups. And obesity as a disease is probably one of the most undertreated diseases out there at the moment. It requires much better understanding of who's going to respond to which intervention. So some patients respond very well to diet and lifestyle interventions, and other patients get no response, while other patients respond very well to a liraglutide intervention and some get no response. So a big part of SOPHIA's objectives is to identify novel biomarkers that will predict response to intervention so that we can give the patients the right intervention from the outset. In terms of risk, my group are really interested in the potential of metabolic inflammation as being a way to risk stratify patients with obesity. So low-grade inflammation is a classic hallmark of obesity, and it's associated with numerous complications from cardiovascular disease to cancer to non-alcoholic steatohepatitis. But it's actually really, really difficult to measure this metabolic inflammation. So it's easy to detect it at the tissue level if you took a biopsy of adipose tissue or the liver, but it's very difficult to detect it in serum. And that makes it extremely difficult to try and screen a population for metabolic inflammation. So my group have identified the HDL proteome as a potential novel mechanism to measure metabolic inflammation, and in particular hepatic inflammation. So I'm going to talk a little bit about that today. So HDL is our good cholesterol. It's inversely associated with cardiovascular disease, and low HDL cholesterol levels is one of the criteria used for the diagnosis of the metabolic syndrome. However, only measuring cholesterol and HDL particles is a massive oversimplification of these very complex particles. So HDL carries over 100 different proteins and 200 different lipids that in turn contribute to the quality of the HDL particles. And the quality of the particles is then linked to the atheroprotective functions of HDL. So HDL in its healthy state has antioxidant functions, anti-inflammatory functions. It promotes the efflux of cholesterol from peripheral cells for delivery to the liver. However, in disease settings such as cardiovascular disease, the proteins that are on HDL change in composition such that more pro-inflammatory proteins associate and anti-inflammatory proteins dissociate from the particles. So HDL particle quality is affected, and in turn function is affected. And this all happens independently of HDL cholesterol levels. So HDL cholesterol is a very crude tool for measuring HDL particle quality, but the HDL proteome is far superior in this regard. And important to this presentation is that 70% of HDL particles ultimately come from the liver, and I'll speak to that later. We accidentally kind of stumbled upon the HDL proteome a few years ago in this mouse study that we did. We fed mice a high-fat diet that was enriched with saturated fatty acids or monounsaturated fatty acids. And both of these high-fat diets induced obesity, and they both increased HDL cholesterol levels, as you can see here, equivalently. So we then wanted to see, well, what about the HDL particle quality in these mice? And what we were really surprised to see is that we could tell what diet the mice were on based on their HDL proteome. So you can see a profound difference between the SAFA group and the MUFA group here, with the saturated fatty acid group accumulating pro-inflammatory proteins that had come from the liver, and a loss of antioxidant proteins and anti-inflammatory proteins was also evident on this HDL. And again, all independent of HDL cholesterol levels. So it looked to us that the HDL proteome was mirroring what was going on in the liver. So we did another study where we fed mice a high-fat diet, and then we gave some mice sodium salicylate. So this is a drug that's an anti-inflammatory drug that potently activates fatty acid beta oxidation in the liver. So it completely protects against hepatosteatosis. And these mice, you can see here on the right, we did liver proteomics, and there was a profound downregulation in LXOR-driven gene expression or protein expression in the liver. And these effects were mirrored on the HDL particles. So the HDL proteome was effectively providing a mirror of the liver proteome, but in an easily accessible biofluid, which is really exciting for liver diseases such as NASH, that the HDL proteome could be a potential biomarker. And this is an area we're exploring at the moment. We then went and collaborated with Professor Donald O'Shea with his obesity cohort to see if our findings in mice translated in humans. And indeed, this was the case. So you can see over here on the left, there's a profound difference in the protein patterns between normal weight and metabolically unhealthy obese patients on the right-hand side here. And again, similar to mice, we saw the accumulation of pro-inflammatory proteins on the HDL within the metabolically unhealthy obese group, and a loss of antioxidant and anti-inflammatory proteins on these particles. And we found an intermediate phenotype in the metabolically healthy obese group. So we wanted to take this kind of complex data set and simplify it. So we created a scoring algorithm based on this data that we call the metabolic HDL index score. And this score could effectively differentiate between normal weight, metabolically unhealthy obese groups, which was really exciting because it's now a linear scale upon which we could potentially risk stratify patients with obesity. Furthermore, we found this intermediate phenotype in the healthy obese group. And this is completely consistent with this being a transitionary state, with many of these patients eventually progressing into an unhealthy state. And you can see by HDL proteomics, these two patients here probably already would fit into that unhealthy obese state. You can see this patient up here has a BMI of 82 and seems to be protecting their metabolic health very well. And then just to point out this normal weight patient here, who you can see very clearly in the heat map, has lost antioxidant proteins and has accumulated pro-inflammatory proteins. So we were thinking that HDL proteome might be picking up metabolically unhealthy but lean individuals who are at 3 times higher risk of cardiovascular disease. But this patient cohort always or nearly always fall through the cracks in terms of disease management. We wanted to see if our score would correlate with components of the metabolic syndrome. And you can see here that it significantly correlates with all the components of the metabolic syndrome, from blood pressure to glucose, BMI, etc. And we've included C-reactive protein in here as our nearest competitor, let's say. And you can see it doesn't correlate significantly to CRP. CRP in turn is a very poor biomarker in patients with obesity, but it's the best we have. So a lot of studies or intervention studies will use CRP as their inflammatory marker. But as you can see here, it doesn't significantly correlate to many components of the metabolic syndrome. The MHI outperforms it in correlation to glucose. Again, MHI score outperforms CRP in correlation to BMI and is the strongest correlate to BMI. And similarly, the MHI strongly correlates to HDL cholesterol levels. So we think our HDL proteome is a novel biomarker of metabolic health. It's a very sensitive biomarker of metabolic health. And for the last couple of years, we've been developing a high-throughput assay with an SFI-TIDA award to try and to create a high throughput assay for HDL proteomics. And this assay is now available. I'm very interested in collaborating with anyone within the institute, particularly if you're looking to look for a response to a dietary intervention or you're looking for a positive impact on health. This might be a very good biomarker. So the next couple of minutes, I just wanted to introduce the project Sophia. So our mission within Sophia is to enable healthcare professionals to reliably predict the complications of obesity and then who will respond to obesity treatment. And I'm really talking here on behalf of Professor Carl LaRue, who is leading this. I'm one of the investigators on the award. It's a 16 million euro award with 29 consortium partners running over 5 years. And this project is being led by UCD, and this is the project management team. And just to highlight Dr. Werd Al-Najam, who's doing a fantastic job as project manager. This is a huge project, a huge undertaking. And our objective, first of all, is to create this federated database of loads of different cohorts throughout Europe. And then we'll be able to start mining this federated database for biomarkers of risk groups and biomarkers of response. And we're doing this for patients who have obesity, for patients who have obesity and type 1 diabetes, and for patients who have obesity and type 2 diabetes. So lots of data analytics going on in the first work packages. Work package 6 will be validating biomarkers identified. And then excitingly, work package 7 is really bringing the patient voice into this project. And this is also being led by Dr. Fiona McGillicuddy in UCD, where we're looking at patients' perceptions of obesity, the language that they would prefer to be used in obesity, and their preferences for treatment. And this leads into this really interesting work package 8, which is the shared value analysis. And this is where we're trying to identify the sweet spot between what pharmaceutical industry can do, what academics can lend their knowledge in, and what patients want, and finding the center of the Venn diagram to influence better healthcare policy making at the European level. And just to point out that this work package itself is being led by a patient advocate. So that's really exciting to have that kind of input and insight. I just want to thank my team. I want to thank in particular Professor Stephen Pennington for his help on the TIDA Award, Professor Carl LaRue and the Sophia team, and then Professor Joan O'Shea for access to all those patient samples in Vincent's Hospital. Thank you all for listening. And again, thank you to the Institute for Food and Health for having me today.